Elias Dakwar is a psychiatrist and researcher at Columbia who has been researching ketamine and mindfulness, among other things, for the last decade at least, probably longer. And he will talk all about his research using ketamine infusion, along with mindfulness and motivational enhancement therapy, not only for cocaine use and alcohol use, and I think cannabis use, and hopefully some ongoing and future studies. So I won't touch on that. I just wanted to highlight what really stands out to me about Elias's work, which is, so in psychedelic psychiatry, in this subgenre, there are a lot of really strong opinions and perspectives about how to administer, even just within ketamine. What is the right way to administer a ketamine? How do we do this? How do we understand the effects? And maybe the more traditional biological psychiatry model understands centers on its biochemical effects and sees its subjective or psychological effects as sort of pesky things to be minimized or avoided. And then the maybe psychedelic therapy model understands the experiential component as central and important. And then there are entrepreneurial and materialist reduction efforts to cram a bunch of ketamine into a small number of sessions, and et cetera. So there's a lot of pressures, there's a lot of different camps and strong beliefs. And what I really appreciate is in Dr. Dakwar's work is he strikes a really sincere and reasonable middle ground. Nothing about his work or his presentation is sensationalized. And so, he does his really excellent, rigorous research. He's not drawing a ton of attention to himself. You don't really hear him claiming that his way is the only right way or the best way. And so I really appreciate, within this field of really powerful medicines and equally powerful opinions, that his posture remains open and flexible and creative. For instance, using the infusion route of administration, but not sticking only to the NIH 0.5 mg per kg protocol, and sometimes using larger doses, and this crucial component of adding mindfulness training. And anyway, so as a young psychiatrist myself, really do appreciate this measured, dare I say, mindful approach to drawing on different skills and wisdom in psychiatry in the application of ketamine for addiction and beyond. So anyway, with that, thank you so much, Elias, for coming to speak with us, and I will turn it over to you.
Thank you for that warm introduction. I'll start to get the presentation up. I was speaking with Yanni earlier about how I hoped this presentation would go. I very much like the question-answer conversational format. So I'll be keeping the presentation relatively brief and focusing on some of the more salient points of my research so that we have some springboards to launch from, and hopefully we'll have a great conversation. So let me just get everything up here.
And while you're getting set up, I'll just say, please feel free to pop questions into the chat, and I will take note of them and carry them, and that will be the substance of our question and answer afterward.
So, you were very generous with your praise. I should give a mea culpa that, while I have been very measured in how I present my data and how I've sought funding in that, I give deference when it's due to the biological model. I find the biological model ultimately far too reductive for really understanding the scope of what we're doing. So I'm glad that I've been chameleon enough to fool you, Gianni. But yeah, I have my reservations about the biological model as much as probably everyone else does in this room. At the same time, I find some of the other mythologies that surround these substances just as problematic. So we'll be focusing, I think, a lot on how to most empirically. I'm sorry?
Sorry, I think someone accidentally
I'm
was
sorry.
unmuted, but it's fixed now.
How to most empirically understand these things. The prejudice that we've been raised with as medical professionals, as Cartesian thinkers, is that the materialist understanding is the most empirical one. But I think we'll come to see that experience is much more primordial than the mythology of materialism. So I like to begin by remembering what we're doing, basically tending to suffering. And suffering has many dimensions. In psychiatry, we often see the dimensions of suffering that can be given a psychiatric label. But these substances, of course, have been used by a variety of people, some of whom don't have psychiatric disorders, and who are at the same time suffering perhaps a quieter way. So as we're going over some of these people who are suffering, we can kind of think about what they might also have in common. So Jade can't stop using freebase cocaine, alcohol daily, finds them indispensable for managing various symptoms. Steve's been severely depressed since the death of his wife 4 years ago, hasn't obtained relief from antidepressants. Stress puts Jesse into a suicidal state. Earl has recurring intrusive thoughts of environmental apocalypse and performs compulsive counting rituals to allay them. Giving some thought to the universality of any particular presentation of suffering is, I think, a very helpful exercise. I think we'll explore some grand theories of suffering, let's say, over the course of this. So, subject of the talk is ketamine. And again, I encourage universalizing this. So the conversation might be about ketamine, but we might be thinking about other substances at the same time. So ketamine was originated in the 60s as an analog of PCP, binds to the same site. PCP was originally developed as a dissociative anesthetic, very powerful NMDA receptor antagonist, has a half-life that is quite long. And most importantly, it allows people to be anesthetized without needing respiratory support, without needing intubation. Doesn't depress breathing as other anesthetics do. Ketamine fits that same profile, except it's slightly less powerful at the NMDA receptor, and its half-life is far shorter. So it's more tractable. It lends itself to clinical use in a better way. It's important to remember the antecedent of ketamine. Colleague Carl Hart has made a lot about this, excoriating the psychedelic community for being complicit, in his words, and allowing the demonization of PCP to further subjugate people of color in this war on drugs. And it's helpful to keep clear on what we're working with here. Ketamine is basically an attenuated form of PCP. And so it has anesthetic effects that lend themselves quite well to use in settings where intubation may not be possible. In the field, in someone gets hurt in a car accident, for example, in the field of war. And in ER settings, emergency settings, it can very quickly induce anesthesia as well. So ketamine has also been found to have subanesthetic psychoactive effects. So if it's given below the anesthetic dose, it produces a range of non-ordinary phenomena comparable to meditation, psychosis, trance, mystical type experience. And initially, its subanesthetic effects were seized on as yet another drug model of psychosis. Later, it was found that it has quite profound analgesic effects at these lower doses, so it began to be used in pain medicine clinics. And then there was an interest in using it in a psychedelic framework that most famously was studied by Evgeny Krupitsky in St. Petersburg, coupling intramuscular ketamine with what he called existential therapy, later ketamine psychedelic therapy, to induce an experience of transformative potential that might help people with heroin dependence and alcohol dependence find enduring sobriety. That research was stopped when ketamine was banned in Russia. Evgeny then came to Yale to study under John Crystal, became a fellow there. And this is sort of the secret history of ketamine's resurgence, encouraged John Crystal to consider that it might have some therapeutic effects in addition to its psychotomimetic effects. And then there was the seminal paper in 2000 where its antidepressant effects were found by John Crystal's group after a single dose, a dose that's become a almost universally used one in infusion clinics, 0.5 milligrams per kilogram over 40 minutes intravenously. Of course, there's a range of doses it can be given at, but that's the one that kind of stuck because of its entry into the field in this way. And John Crystal also has a very biological orientation. He's the editor-in-chief of Biological Psychiatry, chair of Yale. And his shepherding ketamine in this way has led the field in general to regard it, at least in academic settings, from until more recently a very biological perspective, as something that's working primarily as a glutamate modulator with downstream effects on neurogenesis, perhaps effects on the default mode network and prediction bias. But of course, Evgeny's great insight was that ketamine, much like any of the other mind-altering medicines, may be a facilitator of certain kinds of psychotherapy through its psychoactive effects, by either dampening inhibitions, as with psycholytic therapy, which is the name given to therapies that involve these kinds of medicines, not to produce a psychedelic experience, but to allow for free association, for the type of trance that Freud hoped to elicit in his patients in psychoanalysis, as well as in a psychedelic model, which, as you all know, is intended to prepare, guide people through and integrate the effects of a powerful conversion, peak, mystical type experience. So what is happening with ketamine? As I mentioned, its effects are kind of seen by the field as probably mostly biological. And that's due, I think, in part to the larger bias of the field, but also with how it was introduced to psychiatry in this second wind that ketamine is having. So there have been various hypotheses overlapping that have been proposed to account for the antidepressant effect. The first is the glutamate hypothesis. It's a glutamate modulator. It dampens glutamate activity or concentrations in various parts of the brain that may be implicated in the pathogenesis of various psychiatric disorders, but primarily depression. There's the neurogenesis hypothesis that by increasing BDNF or mTOR, ketamine counteracts the synaptic pruning that happens with chronic stress in areas of the brain that may be affected by depression or other chronic psychiatric disorders. There's the functional connectivity hypothesis that ketamine has enduring, very sustained effects on functional connectivity, attenuating hyperconnectivity. It's been shown that hyperconnectivity correlates with a variety of psychiatric disorders. There's the default mode network hypothesis, which the default mode network, I'm sure you've all talked about it in this group. It's sort of one of the linchpins of the biological understanding of psychedelics currently, that the global activity of the brain that coheres at rest, which is responsible for structuring experience, for mental wandering, for ruminations, for the organizational schemes that can sometimes be calcified in psychiatric disorders, that is disrupted somehow and attenuated. A finding that's also been seen with long-term meditators and people entering into trance states. So as I mentioned, these different hypotheses underscore the neurobiological biases of the dominant paradigm. And keep in mind as well that these are all correlational. We can't really, and I'm glad we have a philosopher in the room who can maybe provide some information about this later, but it's very challenging, if not impossible, to create a causal relationship between mind and brain. All we can really do, and I think it's helpful to keep that in mind, is make some correlations, not even between mind and brain, but between what a person is reporting. This is, the subjectivity of a person is not something that we can access ourselves. Just have to take it on faith, I guess. So, as I mentioned, ketamine has a variety of psychoactive effects. It's helpful to maybe recognize what these effects might look like relative to other substances that are popularly used. So this is a graph of some of the more commonly used psychedelics. And we can see here that ketamine largely operates, ketamine is the orange one, largely operates in a way comparable to the others. According to this, there isn't as much an experience of unity, perhaps more disembodiment, maybe less imagery. But I want to make something clear here. This underscores how important it is that ketamine and other substances be given in a setting in a framework that is respectful of their psychoactive effects. Ketamine was not given, these data that were collected, was not given in that setting. It was given to people who were participating in a laboratory study comparable to the medical model of psychosis studies, where healthy volunteers are given ketamine without preparation, without guidance. So that may explain some of the challenges with ketamine in settings where people are not adequately prepared, where they're not given the right support. And it may also explain the difference here between the different substances. I'll be going over psychoactive effects that I found with ketamine in the work that I do that are comparable to psilocybin or LSD. And if we were to chart it on this, it would probably be almost identical, with maybe a bit more disembodiment. So I encourage you to keep that in mind as we look at that data. So as Gianni said, I've been particularly interested in how ketamine might fit into a mindfulness meditation practice. I came at this research from a perspective of having meditated many years since I was a kid and having found it quite helpful for me. And also sensing that it would be quite helpful for people who are suffering from addiction specifically. It's not a huge insight, to have that impression. But at the time that I started my research, there weren't many mindfulness-based therapies. And one of my first projects that concerned itself with addiction was an individual mindfulness-based therapy focused on addiction, which I quite enjoyed doing, but ran into some challenges, which I think we all could anticipate working with addiction. The people that could most benefit had the greatest difficulty engaging with it, and that it's because meditation is a bit difficult to practice. It requires being non-reactive. It requires sitting still. It involves a mindset that may be very different than the one that they've been habituated to having. So in that light, I recognize that it would be helpful to have some support, pharmacological or otherwise, to launch the practice, to give some guidance, to provide some benefits, the vulnerabilities that might make mindfulness difficult to practice. So, mindfulness, just to define it, is not really a particular state. It's a way of giving attention with acceptance, non-reactivity, moment-to-moment awareness. So it's a relationship that one has to one's experience. And the way psychedelic experience may be conducive to meditation practice, it may provide an experiential stepping stone, giving a person an idea of what meditation is like, what that relationship is like, so that they might be able to better access it on their own. May lead to an afterglow of enhanced mindfulness. This has been found recently with ayahuasca. I recently reviewed a paper that showed that it also happens with psilocybin. May lead to changes in openness, reactivity, motivation that render meditation easier to practice. So these sorts of medicines might be embedded into mindfulness training so as to facilitate and deepen the practice. As I mentioned, I wanted to provide a framework that would lend itself as much as possible to the psychoactive effects emerging in a way that allowed for proper engagement. So we gave a range of IV infusions. Participants are taught how to meditate prior to the infusion. Intention setting is oriented around mindfulness-based commitments. You know, people come in with many intentions, many of them pertaining to their addiction, all that they've been struggling with. And we encourage, maintaining that yearning for freedom from their suffering and from all of their problematic patterns. But we also encourage being open, being attentive, non-reactive, non-judgmental, to practice that relationship throughout the meditation practice and the infusion. And the equanimity and dispassion that come with the mindfulness relationship are also intended to disrupt attachment to and reification of the experience. Now, this was something that all of my research, I should mention, is NIH funded. And it was very difficult initially to convince NIH to move forward with this for various reasons, specifically NIDA, National Institute on Drug Abuse, and NIAAA, which is the alcoholism wing of NIH. Because it's first of all, there's a reflexive anathema to the psychedelic model, to even saying that the psychoactive effects might be helpful. I think that's changing now. But especially with drug users, there's a sense of, well, if something is psychoactive and interesting or enjoyable, God forbid, then it will create problems for the person, that their addictive tendencies will latch onto it and create problems. So this was an issue that we had to really address with NIH. And I won't bore you with the details, but one of them included really making a case for why this framework would help with addiction rather than promote an addiction to something new. And the framework, of course, is important for that. So while I mentioned that this was really made explicit to make a case for the substance to NIH, make a case for this research to NIH, it's also important for therapeutic reasons. And we do want to ensure that people are not latching onto the experience, saying, oh, that, I need this experience. The experience is the thing. Mindfulness is about letting experiences come and letting them go and maintaining the relationship, irrespective of what's happening. So they engage in a body scan for 10 minutes while wearing an eye mask. A bolus dose is given, and then an infusion is initiated. There's a minimally guided meditation practice during the infusion. There's a debriefing afterwards. So this model is the one we used for all of our studies, from the laboratory studies with non-treatment seekers to the more sophisticated clinical trials. And one of my research assistants is modeling here for us what it looks like. So as I mentioned, the very people we want to help are the ones who may be most challenging to engage with a meditation practice. So I think a fairly broad definition of addiction is that it's compulsive, reactive, contentment-driven behavior to the detriment of serene, thoughtful decision-making. And an entry into mindfulness may be helpful, given heightened levels of reactivity, craving, ambivalence. And this set us on some laboratory studies to first explore this, like whether that's actually true, whether people will be better in a laboratory setting after a ketamine infusion if they're struggling with addiction. Will they be less reactive? Will they have less craving? Will they feel more motivated? Will they have better decision-making when faced with the drug? So in a small early study, we found that a single IV dose of ketamine versus a control improves motivation to stop cocaine in non-treatment seeking dependent people about 24 hours after the infusion, as well as reduces cue-induced craving. So This is an interesting study. I designed this when I was a fellow, and it took like 2.5 years to do because you don't have much money as a fellow. Um, I finished it during first year of my K award. Um, and, you know, we did it on a shoestring budget. What I was really interested in was, are these really important vulnerabilities affected? Motivation and craving. So what we found was that after a dose of ketamine, 24 hours after, the motivation went sky high, while for the control, or azepam, not much change happened. Similarly, cue-induced craving went far down, and drug liking remained kind of low for all conditions. So we tested 2 different doses of ketamine to see whether there were dose-dependent effects. What's interesting is that while the second dose had an effect on reducing cue-induced craving, the second dose didn't do much for the motivation. They were given all in the same order, the low dose and then the high dose later, in a counterbalanced design, where blind counterbalanced design, where lorazepam could be anywhere. And it was a several-day study. Again, I won't get into the details. The paper is worth reading. But the first dose had such ceiling effects on motivation that the second dose didn't really do much. In a second study, we examined, okay, well, their motivation went up. What about their actual use of cocaine? They were given so they're saying they want to stop, but what if they were presented a choice to use? So we have the capacity to give cocaine in our laboratory. And we designed a larger study that looked at non-treatment seeking cocaine-dependent people, received a ketamine infusion, and then gave them a choice 24 hours later. Do you want to use cocaine, or do you want money when you leave the hospital tomorrow? And we gave them that choice 5 times over the course of about an hour and a half. And we found that people who received ketamine had significantly lower choice behavior for cocaine. So the larger question here is, well, will this help with keeping people engaged with a treatment, especially a mindfulness-based treatment? And will it produce long-term abstinence? So a clinical trial was conducted, a single ketamine infusion, cocaine-dependent people, initiating a 5-week regimen of mindfulness-based relapse prevention. About 50% were abstinent in the ketamine arm in the last few weeks of the trial versus 11% in the control. And ketamine subjects were 11 times more likely to be abstinent than the control group. There were significant reductions in measures of craving and reactivity. There's also a increase in time to first use or dropout in the ketamine group. They were less likely to use or drop out. We did the same general study on an outpatient basis with ketamine and alcohol users. Incorporated a single ketamine infusion into motivational enhancement therapy. People who received the ketamine arm, they remained abstinent with fewer use days than the midazolam group. And there was a comparable delay in time to first use or dropout. So I mentioned that the psychoactive effects are interesting. I want to get through this so we can have some time to talk. So this is a modified Hood mysticism scale. It's commonly used in research of this sort, where we're trying to investigate the psychoactive effects of these substances. And you can read here, the experiences are fairly comparable to states that are associated with a religious conversion experience or something that leads to existential reappraisal. Had an experience in which I realized the unity of all things. I had an experience filled me with awe, a new view of reality, holiness, aliveness, perfectly peaceful, something greater than myself, something ineffable, something beyond space and time. What you see here, I divided the different dimensions of the mystical experience, that we can examine the dose-dependent effects. So both conditions, both ketamine conditions, separated from placebo, while the higher dose separated from the lower dose as well. So this suggests dose dependence, on some domains more than others, but the total score very clearly so. Now, ketamine has been, identified as dissociative, but clearly it has other effects that are important to understand. We did a mediation analysis. So mediation, as you guys know, is the necessary intermediate between a medicine or intervention and its effect, its primary outcome, whatever that might be. And a lot has been made for the importance of the psychoactive, for a certain type of psychoactive experience, and the way ketamine works and the way psychedelics more generally works. So we investigated that question in the study with 20 participants that I mentioned, the non-treatment seekers who were given the choice to use cocaine. We collected information on mysticism, on near-death experience, on dissociation, and then we created a global improvement score to incorporate the improvement in choice behavior and craving and use on an outpatient basis. And we found that there was a pretty tight correlation between mystical experience and global improvement. Furthermore, we found that only the mystical type experience correlated with, in a mediating way, with outcome. So that means that it was a necessary intermediate for ketamine's efficacy in this respect. So these mediation data suggest that engagement of consciousness in a certain way is crucial to ketamine efficacy, and that it's not all experience, but only a certain kind, mystical type experience that suggests this. And one way of understanding this is that a certain mode of engagement is disrupted, so that fuller consciousness might awaken. And this is consistent with both neuroimaging data with psychedelics, meditation, as well as with the school of thought, let's say, from which mindfulness emerged, the Buddhist, Vedantic, Vipassana understanding of consciousness, where consciousness is the primordial reality, and it's joyful and peaceful and compassionate. And what happens is we become unmoored from it and get caught up in surface agitations, having to do with the trials and tribulations of being an ego, the various attachments that we might have, patterns that we're locked into. So return to our initial phases of suffering. Those with depression, addiction, PTSD, OCD, other mental health issues, as well as healthy, casually suffering people, they may all respond to ketamine, and perhaps other psychedelics. Why is that? So the brain model would suggest that the problem is overlapping pathophysiology, shared glutamatergic disturbances, synaptic pruning, functional connectivity alterations. This is the dominant way that we understand psychiatric pathology, that there's something going on with the brain that needs support. The phenomenological model suggests that it's the agitated mind, that consciousness, experience has been kind of affected in some way through attachments, aversions, reenactments, ignorance, and that this has compromised a certain primordial capacity for serenity, wisdom, contentment. So I mention this because, we're taught to see this latter model as the less empirical one. But if we were to really just pay attention to what we're going through, which one is more empirical? Like the fact that our prefrontal lobes might be, having too much glutamate, or is it that we're experiencing something that's unusual and we can experience it differently and feel better? Now there may be brain correlates to that, of course, but experience is the thing. And of course, we would be considered maniacs if we disregarded whatever our patients were telling us and went straight to the neuroimaging suite to really get a handle on what's going on. So yeah, which is more empirical? So what about the non-addicted? This model has relevance to depression, OCD, suicidality, PTSD, the many manifestations of an agitated mind. And I would say that, the disconnection that can occur from the reserves of serenity and calm and dare I say wisdom that we all have, where a lot of psychiatric difficulties stem from. And our work is to help people return to that, often by dampening whatever agitations might be happening. But just as important is re-engaging them with that fuller consciousness, which is available to them. Mindfulness, meditation, other mind-body practices are one way to do that. But things like ketamine, like other perhaps mind-altering medicines may also be helpful in that regard. So ketamine providers understand this in the community and are more likely than researchers to embed infusions into therapy. They're not giving it as standalone treatments generally. They recognize the psychoactive effects are at least important to attend to, and will provide a space and a framework for them to emerge most fruitfully. S-ketamine providers are more likely to view it as a standalone intervention. And that is primarily due to the instructions that S-ketamine providers get from Janssen, how to provide S-ketamine. S-ketamine, of course, is the S enantiomer of ketamine that has been patented by Janssen as a way of moving ketamine into the marketplace. Ketamine is a racemate that is generic and has been around, as I said, for decades. So S-ketamine is the more potent enantiomer of the two on NMDA receptors. And so S-ketamine emerged, was barely approved by the FDA for treatment refractory depression and is now being used in communities. Though it's probable that it's not as effective as the intravenous ketamine route or even the intramuscular. So it remains to be seen what what the future of esketamine is. There's also some research suggesting that the R enantiomer may be helpful in its own way. From a biological perspective, causing neurogenesis in a way that is very different from the way esketamine does. So for the IV phobic, other routes of administration, intramuscular, oral, subcutaneous, intranasal may also be helpful. Oral route, especially at lower doses, may be more conducive to psycholytic approaches. So to conclude, what addiction highlights is the great suffering that emerges from an agitated mind and how we might disrupt that through various means. The experiential effects of ketamine and addiction suggest psychological mechanisms, and these might be deepened and extended by a mindfulness framework, as well as by giving attention more generally to the psychoactive effects. This is a picture of my lab from a few years ago. I have, a lot of people to thank, my collaborators, NIDA and IAAA, participants most of all. Well, thank you for listening.
Thank you, Elias.
Yeah, thank you. Let me just get out of this here for us. Stop share.
Yeah, it just, again, I apologize for getting meta here, but experientially listening to your talk, it kind of paralleled the content in a way. There's a resonance there with kind of staying with the material and being mindful. I want there's so many things I wanted to say, and I'll leave it to the audience to propose questions. One thing that you're touching on that's making so much sense, in the psychedelic research we're seeing, it almost feels like a panacea, because you see, psilocybin for addiction and depression, and being trialed for end-of-life cancer, anxiety, etc., and ketamine as well, depression and suicidality and addiction, as you show in your data. And it lends to this idea, which is not specific to psychedelics in psychiatry, which is, what is there's this common psychopathological factor. Why do we see such high comorbidity? Why is depression comorbid with anxiety and substance use disorders? And people have all kinds of theories, but I just wanted to read one quote from this paper from the mainstream psychiatry a couple of years ago. Again, not that I'm in that camp, but it just so directly speaks to what you're talking about, Elias, here. It's talking about what might be this common factor uniting suffering among people who we label differently. It says, and this is from 1947, a psychoanalyst and neurologist, Ernest Jones, who apparently was also Freud's biographer. It's the capacity to endure the non-gratification of a wish without either reacting to the privation or renouncing the wish, holding, as it were, in suspense. And then he talks about how that might be correlated to some neurological capacity. But I think that's kind of a different way of saying exactly what you're talking about, this capacity for mindfulness and non-reactivity that the agitated mind is without.
Yeah, I think for a long time, I would say millennia, it's been recognized by the Buddhists that the origin of suffering is getting entangled in our likes and dislikes, and learning how to move beyond them and maintain a path that is more dispassionate and equanimous. So I think the one novelty to what you just read is that, and we should look in the brain for where it might be. But yeah, it's a bit unfortunate that that's our main contribution, to start kind of digging into the brain, as opposed to providing frameworks for entering into those states of consciousness, or those processes of consciousness that have been recognized for a very long time to be so therapeutic and helpful and compassionate.
Yeah. And again, I'll just refer a couple. I will hand this over, I promise. But when I really appreciate too how you connect how addiction is just a very visible example of being in a, experiencing cravings and not being able to access that more mindful or um, yeah, the more mindful state. And what's I like about that is that's something I experience. That's something everybody can relate to and experience is having this sense of agitated mind. And so it speaks to this idea of universality of a process which is manifests more visibly in some. Um, anyway, so to the questions, have you noticed any relationship between the dose of ketamine used and its effects on mindfulness, either in the moment experientially while on ketamine or afterward?
The research pertaining to that question hasn't been rigorous enough to answer that question empirically. Um, but I would say from my clinical practice with ketamine, some more clinical impressions are that ketamine at higher doses causes quite profound dislocations, where people are no longer in this world, traveling through space or communing with ancestors. In John Lilly's case with dolphins, and that isn't really, let's say, a mindful. It can involve mindfulness, but it's not. It doesn't lend itself to mindfulness so much as it does to exploration, and of really going to the limits of consciousness. Which brings me to another point, which it's a finding we recently, Rebecca Rothberg was brought up earlier, mutual friend, and we did a paper recently where she analyzed the mystical type effects from the alcohol trial that I discussed briefly, and looked at the individual dimensions of the mystical experience to see whether there were certain parts of it that were particularly correlative with improvement. And what we found was that ineffability was really important. And I think that's a very profound finding. So, again, one of the kind of pop hypotheses how these substances work is they rewrite our story, right? Like we have a story, and these substances give us an opportunity to rewrite our story, to find a better way of engaging with our life that is more positive, let's say. But it could be as well that these substances work by just transcending the story altogether. Like there's no story. Like ultimately, there's no story. Like at heart, everything is quite mysterious, and that can leave an impression that there might be some stories that are fruitful to use in certain settings, but at bottom, things are incomprehensible. Like we just don't know. And the mindful state, in part, is a suspension of those certainties of that kind of knowing, of discursive understanding more generally, like being able to put words to things. And so even at those outer reaches of consciousness, if we're getting that impression of ineffability, and ineffability of the true sort, there's ineffability, like you have some very beautiful aesthetic experience or some great insight that it takes a while to kind of realize, communicate. That's not quite ineffability. Ineffability is absolute muteness in the midst of whatever it is we're experiencing. And that's something that can be very helpful to remain engaged with. Like just keep your words in their place. Like they're just tentative approximations that ultimately are only as helpful as we allow them to be. In other words, yeah, I think while maybe different doses may be helpful at the practice of mindfulness, at engaging in a mindful way, ultimately we can still move forward with heightened mindfulness if we approach it appropriately.
Yeah, wow, thank you. Boris, you want to go ahead and ask your question?
Thanks, Johnny, and thank you, Dr. Dakwar, for a very in-depth presentation. And I wish you had time to go through more. I was curious. I didn't realize how much your model of therapy looks like what some people call ketamine-assisted psychotherapy. The CAP. There, people have published on. There's at least one RCT. It's not even an RCT, actually. One clinical description is from Phil Wolfson, Jan Dor, and a few others. I'm wondering if you could kind of compare what you do versus what, at least your understanding of what they do is. And I know there's variation.
Phil's a friend. Yeah, I admire Phil. He's been doing this a long time. And I think the ketamine-assisted psychotherapy model is very much a psychedelic frame. There's an understanding of the experience as transformative, and so the hope is that the experience will be the pivot around which the clinical improvement occurs. You know, I have a slightly different model in that, you know, I have to admit, I flinch a little bit when people talk about their experience being, you know, the top 5 most important. Because I want to get people to a place where like every day is important, every experience is important. Like, wow, that coffee this morning, you know, and fetishizing a certain experience or getting kind of caught up in it or creating a mythology around it. I don't really see that as the type of relationship to primordial experience that I'd like to guide people towards. So I think that's where the biggest paradigm shift between what I'm doing and what the psychedelic model is about. I'm more interested in creating a certain relationship, a certain process, as opposed to an experience that one, you know, continues to return to or sees as even crucial to health or well-being. I think with our eyes wide open, like all of our eyes open, however many we have, you know, experience is, you know, it's always quite intense and interesting. And that's what we should all be aiming at, I think.
Elias, these are a couple of the more profound things ever said at the Stanford Psychedelic Science Group. So thank you both for the explanation and the, I don't know what you'd call it, teaching or entertainment, but loving this. Nicholas, I think you were next asking a question about music. I don't know if you're out there, you want to go ahead and ask.
Yes, hi, thank you, Dr. Dakwar, for this really fascinating talk. I wanted to know, I'm a resident in psychiatry and we are working in treatment-resistant depression here in Montreal at the Douglas with a kind of a bit, not a psychedelic frame, but an integrative model. And we use music during the infusion and we are trying to incorporate a bit of mindfulness, doing body scan. And I was just, I wanted to know if you considered at some point introducing music during the ketamine, or why you decided not to introduce music.
Yeah, that's a great question. I think again, I came to this from a meditative standpoint and was very interested in helping people enter into, I guess this is my bias, so I'm sure you can meditate to music, but a kind of engagement with silence and with what's beyond our usual coordinates. To be able to inhabit total dislocation, total like total removal from the moorings of normal consciousness, but in a way that felt at home at the same time. So music to me is too much of this world.
Okay. Thank you.
Not that it can't be helpful. I think it can be quite good for relaxing people and allowing them to get into the state. But yeah.
It's a bit too directive in a sense.
I'm sorry?
It's a bit too directive in a sense.
Yeah, in a way. Yeah, in a way.
Thank you.
Thanks, Nicholas. Lisa had a question she wanted to ask about the specifics of the mindfulness practice you use.
Thank you, first of all, for your presentation. So I think the word mindfulness is thrown around a lot in psychiatry without people really understanding what it is. So I trained in mindfulness, and what I'm having a hard time with, and I want to know a little bit about the specifics of what you did, is that I tend to stay away from any grounding mindfulness exercises past anywhere between the first 40 minutes of the infusion, because I do believe that there's something sort of like, I don't know, ephemeral happening in the body. So I stay away from that. And that's why I don't like body scans, because they're very grounding. Did you use a specific type? Did you use Sense Door? What kind of mindfulness practices
That's a great question. Yeah, it's a great question. So as you were talking, I was thinking about Nicholas's question. I would say that the body scan is sort of what we do prior to the infusion. And it's a bit like the music of the body. Like they just sort of like listen to their body and kind of get comfortable with their body, get comfortable laying down, so that when the infusion starts, they're already in a state of receptivity or a state of relating to their body that allows for kind of moving that relationship in a different direction. So again, the body scan, I guess, is not intended to ground them, which I don't necessarily see as problematic. It's more to allow them to relate, to begin that process of relating, of being mindful, so that it is something that they can continue practicing through the infusion with whatever the infusion is doing. And sometimes infusions can be, despite ketamine's reputation for disembodying people, it can be quite visceral and physical and earthy. And one has to be prepared for whatever happens. I hope that answers your question.
It does, because I really am fearful of interfering in the psychedelic process. And I think for me, we teach a mindfulness-based course for 1 month, and we have patients that are doing TMS and ketamine do them because they're my patients. And I always wonder about if I'm interfering with that experience.
Yeah, this is interesting, this idea of interference. I'm going to switch gears completely and say, like, sometimes, I don't know how many people here have participated in like traditional shamanic work, for example, but like it's all about the person engaging with you in some way and directing, and it's part of the power of the experience. So the sort of sovereignty of the individual might be one of the fictions that we're that that we're caught up in. And it's, you know, sometimes for that disruption to occur, someone needs to spit water in your face, or, you know, any of the other things that might happen in shamanic work. So, you know, I'm not going to be spitting water into the faces of my patients who are getting infusions, but I recognize that this is a model that's intended to work with the existing paradigm. And it is one way of helping people step outside of whatever it is that they're caught up in. But it's not the only way. Music might be helpful in other circumstances, dancing, you know.
Probably a good way to get the IRB or the NIH to turn you down to propose spitting water in people's face after the infusion. So we'll avoid that for now. Think of more palatable ways to disrupt the narrative.
I think it has effects on the insula, though, so we might be able to.
Exactly, disrupt the default mode network. Anyway, thank you. Janus, did you want to ask your question?
Yes, thank you. Hello, Dr. Dakwar. Always great listening to you speak. This is my third time in a couple of months, so always leaves me with lots to think about. I'm a fellow CAP practitioner here in Toronto, and I had some technical questions. I saw your range that you were using 0.7, 1.4, which is quite a ways from the gospel 0.5. So I was just wondering if you could comment on that. Are you sort of leaning towards the higher doses, since it seems that from your data, the higher doses were more conducive to the mystical experience, which led to further improvement or global improvement? So I'm really curious about that. And if you are, how are you battling the fact that 0.5 is sort of is the standard in the field, like medical, legally, and all sorts of ways?
I think it's a good question. Well, it's not really a battle I'm interested in having. I'm more interested in exploring what the different doses might be, and then putting the data out there, and then people can draw their own conclusions. I think most people who work with ketamine regularly have learned to play with the dose, because not everyone responds the same way. And you know, one caveat I would say about that is, you know, there's this notion of the holy grail. Like, what we're trying to do is to get that peak experience where everything changes. And you know, I think that's where this sort of modality can get dangerous. Like, we start to chase a certain experience. And you know, my intuition is that it's not really about the experience. Like, the experience is okay, but it's about a certain relationship that can happen. And you know, sometimes through you know, the grace of you know, the powers of that be, there's some sort of intense relationship, an intense, like, let's say, elopement, like a marriage in Vegas, and suddenly, like, things are very different moving forward. But sometimes it's a gradual process of helping someone kind of develop that relationship with time and with work. And so, as far as the doses go, I would find the one that feels comfortable for the patient and that allows for the work to be done, even if it's relatively modest work.
And how many, if I may follow up with that, how many sessions do you typically do with the patients?
So in the research setting, I started with one, and now we're up to 3 over the course of like 8 to 12 weeks. But I would say even that could be more frequent. We haven't analyzed yet the larger trials that are incorporating more frequent infusions. But it looks like these additional infusions are helpful. Just from some preliminary analyses. In clinical practice, I just monitor people, and when they start to feel like they need potentially some catalyst or some extra support, then we would do it again.
Thank you.
Yeah. It's good to have just in general a relationship with your patients where they're feel like they're in a position to inform the process in a responsible way, and especially for these substances where experience and subjectivity are so important.
Thanks, Elias. And I want to be mindful of your time. I know it's approaching 9 o'clock where you are. Maybe just a couple more questions, and then we'll let you go. Anyway, I see Mona, I just saw your video. I know you had a question. Before I butcher it, maybe you can ask it yourself if you'd like.
Hello. Thanks, Dr. Dakwar. I do ketamine infusion therapy and ketamine sublingual therapy in California.
Mm-hmm.
And my question is kind of a tangent. I was curious about the difference that you mentioned between racemic ketamine and S-type ketamines like S-ketamine, and why racemic might be more associated with a greater degree of neurogenesis and possibly more effectiveness. And then a more like related question is like, I'm curious what challenges you encountered trying to teach people to integrate mindfulness, meditation, and ketamine, and how you address that, or what you've learned from that. Some takeaways would be much appreciated. Thanks.
Sure. So the head-to-head comparisons of S-ketamine and ketamine aren't really there yet. So that has still to be done. I've heard whispers that Janssen is not interested in that happening because they're fairly sure that ketamine will outperform S-ketamine robustly. So I can't really comment. Anecdotally, I've heard that ketamine is somehow softer than S-ketamine. That S-ketamine has a bit of a bite to it, and can feel maybe, in the words of a colleague, speedier. She's done both. As for what accounts for the increased neurogenesis with racemate, Hashimoto in Japan, has been really the most active researcher in this area, looking at R-ketamine in animal models, comparing it to S-ketamine, comparing it to racemate, and he tells a very compelling story that R-ketamine promotes more neurogenesis than S-ketamine, and that it works through a different pathway. So that even if you're, inclined to stay with the racemate as opposed to R-ketamine, that because there are some companies now developing R-ketamine, saying, oh, this is the holy grail. This is ketamine without the psychoactive effects, because R-ketamine is not nearly as psychoactively potent. It doesn't cause the dissociation, mystical type experiences. So even if you're inclined to use R-ketamine over racemate, racemate still has these other pathways, that through the S-ketamine. Now that might be helpful. And then your question about mindfulness and ketamine. So with fellow practitioners, I think most practitioners who understand what ketamine does and what mindfulness does invariably will have mindfulness somehow involved in the process. Whether you know, other clinicians will do that. I think with mindfulness, it requires being mindful yourself, you know, having that understanding and that relationship to experience and to being, to be able to really impart it effectively to people. So it's not something like, you know, a manual to give to people and say, you know, you should start doing this. It's really a shift that needs to happen at the level of the provider herself. And as for the challenges that come with teaching or encouraging participants to adopt it, I think it's you know, the obvious issues of, you know, I don't have time to do this. Yeah, I think I believe it's helpful, but you know, I just don't feel like I'm meditating properly. Some challenges with like a perceived theistic element to it. Maybe some contrarians who are sick, as most of us are, of like this mindfulness in every setting trend that's going on, like, you know, be a better CEO and take this mindfulness course. So, you know, there are lots of challenges. I think the important thing is to make it relevant to the person, and every person, bar none, just wants to feel better. You know, like I just, you know, want to feel more at peace, like just not have to deal with the usual stuff, and at the same time feel like I have access to feeling better easily, you know, without having to contort myself or do things that are potentially damaging to myself. So approaching it from that perspective can be very helpful. Like, you know, this is a way that you've had intimations of before, you know, when in a, you know, so-called flow state, or when engrossed in something, watching a movie, you know. Well, how about being able to access that at will, and being able to maybe have that be a consistent part of your life, a consistent current running through your life. I don't know anyone who would resist that offer, you know. And mindfulness is ultimately about a relationship. So I talk about the practices as sort of like doing push-ups, but they're not ends in themselves. It's the, you know, it's feeling better. It's having an increased capacity for entering into those states between push-up sessions. And I think that can reassure people that this is not, okay, I'm just going to just do these really sometimes unusual exercises and that's it. Like, you know, helping them recognize that, you know, this is something that can endure and that you can continue benefiting from.
Thank you. And again, just checking in, Elias, are you good for just a couple more minutes, or are you?
Yeah,
taking
one
off?
second. 1 second.
So, Wisdom at 5 p.m. on a Monday evening by Dr. Dakwar.
Sorry, I just have to, there's a patient that I was supposed to, let me just. Hey, sorry, go ahead.
Oh, just going to sneak one quick question in from earlier, Danielle. I wanted to let you ask, I think you were asking if there are any further time points measured specifically for cocaine abstinence after the initial time points.
Yeah, so we also asked at 6 months, 3 and 6 months, and I don't remember offhand what the rates were, but yeah, a majority of people who were abstinent remained abstinent. So the effects endured. One thing I should say about giving ketamine in the cocaine trial. So we really wanted to make the most of any window of opportunity that might open up after an infusion. And the bulk of the meditation training actually happened while they were inpatient. So it was an inpatient/outpatient study. They were inpatient for about 5 days, during which they received the infusion, ketamine or control. And there was a fairly intense meditation training that happened over that time to really strike when the iron was hot, so to speak, and that may have accounted, I think, for some of the persistence. Like we really had them insulated from the patterns of the outside world, and were able to just engage fully with the experience. The other thing I would say is, presented in a certain way, clinical trials can also be received as this like very special thing that someone is getting, so that it heightens the, not necessarily expectancy, but the uniqueness of it. Like, this is a unique opportunity. I don't know what I'm gonna get, but it's, you know, there are these very fancy doctors are giving me a lot of attention and really helping me as best they can, and it's free. So I think this sense of receiving a gift that is intended to be like valued and appreciated and recognized may have a lot to do with some of the persistence as well. They kind of, so it's not like they return to the experience of the infusion. They return to this experience of generosity that kind of calls their attention perhaps to the larger generosity. Again, to this abundant experience that underlies all of our waking moments that we sometimes get disconnected from.
Thank you, Dr. Dakwar. I do have one quick follow-up. I know it wasn't a huge study, but can you say anything about the demographics of the patients who participated? Do you remember?
Yeah. So the laboratory studies, they were mostly African American men who were free-base cocaine users. The cocaine trial was about 45 to 50% African American men, 20% Hispanic, and about 30% white. In the alcohol trial, it was mostly white. Yeah.
Thank you so much.
Mm-hmm.
I think that this is a bit of a stretch, but speaking to the importance of all this preparation and attention aside from or before the actual infusion, is a nice lead into Jen's question, I think, which is about preparation not for the participant, but for the person sitting with the participant.
Yeah, so I'm wondering about what type of preparation, training, learning your team went through, or if that was an existing foundational knowledge base that everyone already had. So I'm curious about that. And then just quickly, because of something you just said, for the enduring effects of the cocaine trial, I'm wondering, were participants engaged in mindfulness exercises in those 3 to 6 months after? Is that something you measured? I may have missed that.
We didn't measure that, no.
Okay, so then the first question.
Yeah. So as far as training goes, the therapists who are involved have all had, because they're involved in other trials that I'm involved with, like they've had training with giving psilocybin or MDMA through getting trained by MAPS. And I've also trained them in mindfulness based relapse prevention. So they're fairly sophisticated at doing this kind of work.
So it's a combination of, it sounds like, existing psychedelic assisted psychotherapy model layered on with a mindfulness training that you've provided them.
Yeah,
Is that fair?
I think the psilocybin MDMA MAPS model or Johns Hopkins model, that was more fortuitous because the therapists who wanted to engage with our work had already kind of been involved in that work, or were still involved. And so I mean, it's good to have that, but I think having some comfort with intense states is crucial. So some experience with just working with patients who are really suffering is helpful. And I think some mindfulness training is helpful. I'm not sure that the other models would be necessary, but they're good to have.
Thank you.
And then maybe just our last question. I think, Rachel, if you want to go ahead and ask, I'm just curious about the range of ketamine's effects and how that bears on its therapeutic properties.
Yeah, I'm really interested in like the neurological side of this. And I saw that you kind of mentioned a little bit of like the brain theories about it. So I know I recently learned that ketamine kind of mimics the symptoms of schizophrenia, and I thought it was really interesting to find out that kids don't really experience the psychosis part of the ketamine in the same way that kids don't typically develop schizophrenia until after puberty. I thought that was really interesting. And anyway, so since this can treat all these other disorders, do you have any thoughts on how this might relate to like the biological differences within these diagnoses? I know that there has been some suggestions that maybe it has to do with the default mode network, but I'm wondering if you have any other thoughts.
Yeah. Well, one biological model, let's say, that is compelling is the disruption and prediction bias that can happen with these sorts of substances. So just to give a primer on that model. So one way of understanding our perception of the world and of ourselves is that we're constantly generating hypotheses to make sense of what's going on. And there's this kind of a mechanism where the hypothesis is tested against incoming information to see how well it predicts whatever's happening. So it's sort of like we have this internal scientific process that's going on, where a hypothesis is generated, and then if it fits what's happening or kind of models what's happening such that we can make good predictions, and it's what we stay with. What these substances do is they can disrupt that process where the incoming material, let's say, is so outrageous that the usual hypotheses aren't kind of working out, and there's what's called like a prediction mismatch increase. It's also, been more loosely called like more entropy. And I would venture to say that, you know, what can happen in a range of psychiatric disorders is that the mind gets constrained to only a few kind of maladaptive problematic hypotheses that kind of continues to be thrown into the world in a manner that isn't really moving the person smoothly through things. In fact, may create psychotic symptoms where, oh, you know, of course, if I see that person smile a certain way, it means that he's trying to kill my mother. Or it can be more of an addictive hypothesis, like, you know, whenever I feel this way, it means I need a drug. Many different manners of narrating experience or constructing experience that present as psychiatric distress. So, you know, I think that's an interesting model that may be helpful. But, you know, it's interesting, you know, but I think we're back to that question of like, what are we really aiming at? Are we aiming at like helping people make better hypotheses? or are we trying to, you know, trying to get people to enter into just a more whole way of being? So yeah, I think it's an interesting model, but it has its shortcomings.
Thank you.
Well, thank you so much, Elias. You've been really kind with your time and generous here.
Glad it was helpful.
And I have to say, this is one of my favorite talks that we've hosted, especially this Q&A part. It was hard to find a question that wouldn't lead into something profound. If I could clone you, I would, and we would have a wisdom hour with Elias every week. But that's maybe hyperbolic. Anyway, we won't. No cloning, no spitting in the face, water, NIH. Bottom line is, thank you so much. Really appreciate the thoughtful responses.
Yeah, it was great to be with you guys.
Yeah, and thanks everyone for coming, and take good care.
Bye, guys.